Hello, everyone. My name is Scott Luhmann. I'm a professor in the School of Medicine at Washington University, Department of Orthopedics. I am here today with...
My name is Brian Kelly. I'm an assistant professor at Washington University. Very excited to be joining you this afternoon and be talking about one of my favorite topics,
which is idiopathic scoliosis. Both Brian and I spent a lot of our professional career taking care of idiopathic scoliosis and other scolioses in children only. We are at the Shriners Hospital and St. Louis Children's Hospital through Washington University. And so we're going to have a little chat today between Brian and myself talking about idiopathic scoliosis. And we encourage anyone to ask questions, please insert them into the chat. We'd be happy to answer them during and after we get done talking. So please feel free to insert any questions into the chat. So Brian, I'll just start off asking you a question. Tell me, what does idiopathic scoliosis mean?
Sure. So scoliosis, kind of its most simple definition, is a sideways curve in the spine. When you're looking at someone, when the spine curves off to the side, that's how we define it. It can happen for a bunch of different reasons, but far and away the most common type of scoliosis, we call it idiopathic scoliosis, which really just means we don't know why it happens. Even in 2020, almost 2021, we still are trying to figure out exactly what causes this most common type of scoliosis. It makes up 85% or so of all scoliosis. And most commonly, we are seeing idiopathic scoliosis in adolescence. So right around the growth spurt is most commonly when these curves are starting to appear and when they're going to be at their highest risk for progressing and getting worse.
Right. So you mentioned the adolescent idiopathic type, and because it doesn't have a cause, we don't know, but it hits at other ages also. So, you'll see babies that have idiopathic scoliosis, but we're going to focus our discussion today on adolescent scoliosis just because it's an easier topic for us to get in 30 minutes, but it encompasses the entire spectrum of ages in kids. And so as we look at idiopathic scoliosis, Brian, what are some of the things that you've heard that are the most recent hot topics as far as what may be causing scoliosis, this idiopathic scoliosis? Because there's a lot of new innovations and discoveries.
So definitely get lots of questions from families about the genetics of scoliosis. So mom or aunt or someone may have had scoliosis and always ask if it's something that runs in families. And the answer that I give to people ask that question is yes, there is a genetic component, but it's far more complex than mom has it, all the kids have it, or brother or sister have it, then we expect all the siblings to have it. That it probably involves a number of different genes and their interplay, and no one single gene that we can just test for and say, here's your risk for scoliosis, here's what your scoliosis is going to look like. But there's a lot of effort along those lines in terms of trying to better understand what the genetics of scoliosis are. I think while we talk about it being idiopathic, there probably is some underlying cause, and it may not be the same cause for everybody. That it could be a number of different issues. We know that children who have disorders that affect the connective tissues in the body tend to develop scoliosis. So there could be some sort of undiagnosed connective tissue disorder that we don't really, kind of subclinical that we don't diagnose formally. So kind of the things that I'm thinking about in terms of what we're trying to figure out right now, and understanding why the spine kind of grows abnormally. What could be causing that?
And then one of the tests that came out many years ago was that Scoli score. That we swabbed a bunch of children and they were doing some collection of information. Unfortunately, that really didn't help us all that much to predict who was not going to progress and need treatment. So we don't really use that anymore. I'm not sure it's used very much anywhere at the present time. It just didn't show that it was very predictive. And just as you mentioned, that there's so many different factors, and probably a lot of different genes that goes into this, that it's not just one gene causes scoliosis. And so it is something that's still under a lot of investigation trying to figure it out. So I guess you're saying then is that if mom has scoliosis, the kids won't get it. But it seems like most of the people that I end up seeing have no family history at all of scoliosis. Is that what you've experienced also?
Yeah, that's my experience as well. I think we know that you're at a higher risk if you have a close family member, but a vast majority do not have any scoliosis in the family. But always something that I ask for.
So tell me, how do you what do parents look for? I should probably say, for scoliosis. Even if they don't have a family history, they want to check out their child. How would you say that parents could kind of keep an eye on their child?
So I think the number one thing that I would tell parents is you do not have to be making this diagnosis for your child. That it can be very subtle. That the first and foremost, you want to make sure that your child is getting regular checkups with their pediatrician. That typically scoliosis, especially as we get towards the adolescent growth spurt and this time where most scoliosis is going to develop, in particular at that time, pediatricians are taking a closer look. Now, in terms of what parents can be looking for, it's really asymmetry is what we notice on exam. So that can be shoulder asymmetry. The shoulders look not level. The waist or the hips don't look level. The body appears shifted to one side or the other. And then the test that we typically use as a screening test, and this is not something that parents are going to be seeing kind of on a normal, regular basis, is when the child bends over, you can actually see one side of the back is higher than the other. And parents may remember doing that test in school, school nurse having them bend over and touch their toes. But that gives us a look at the rotation that goes along with the scoliosis, and we use that as a screening test. But all of these changes, all of these asymmetries can be very, very subtle. So it's important to be seen by your pediatrician regularly, and they should be screening at least a couple of times during early adolescence, but ideally every year when they see them for their well child checkup.
Yeah, it's often interesting when parents are very, very surprised when they go to the pediatrician just prior to school starts, and they're mortified when they're given their child's given the diagnosis of scoliosis. They've feel like they've missed the boat, that they missed something, that it's their failure to not pick it up earlier. But at that age too, they're not seeing that person like they were when they were giving them baths when they were 2 or 3 years of age. They don't see their backs. And a lot of scoliosis, as you were talking about, when they start wearing clothes, especially over the fall, winter months, that you don't see some of that asymmetry popping up. And so they first see it, either pediatrician sees it. The other thing is when it gets warm up outside and they start wearing their bathing suits, parents pick up that sometimes, but they're absolutely mortified. I mean, it's as if the parent thinks that they caused it or they've missed the boat. Can you, what's your experience with that kind of feeling that the parents have? I
totally agree and see that very frequently. What you're saying, I think for those really young kids, the 2-3-year-olds who are getting baths from mom regularly, definitely see more of those kids getting picked up by parents rather than the pediatrician. And you're exactly right. Mom and dad are not looking at your back without with just a bathing suit on, or it's very subtle changes that sometimes difficult for us to see or the pediatrician to see. And there is, definitely see lots of families coming in with guilt that they missed something. And that was my point earlier. It is not your job to diagnose your child with scoliosis. You're being a good parent, taking your child to get regular checkups. You're bringing them to see a specialist, you're doing everything you need to do as a parent. Now, that said, if you do see something that concerns you, if you do see changes or those asymmetries, you know, just bring it up with your pediatrician, give them a call. But there's definitely a lot of guilt around this, and people do feel like they've missed the boat.
The common question I get, Brian, is but what could I have done differently to prevent this or to take care of this? There's really nothing people do for this particular diagnosis. There's nothing that you can do to say by getting that 2 months earlier that it would have changed something for the child. It's very difficult to see, and especially when the kids have two curves. They have two curves, they balance out very well, and actually seems like when they have just one curve, either up high or down low, it's much more obvious for us to see. And those kids come in with a lower magnitude of a deformity very, very early because, as you mentioned, the shoulders are off their waistline. So that's very common to be seeing. So, so what would you, when someone has a suspicion and they take it to the pediatrician, what step for an evaluation? As far as imaging, what do the pediatricians or what do we get to make the diagnosis of scoliosis?
So generally, when we are evaluating for scoliosis, it starts with the examination, looking for those asymmetries that we were mentioning. And if we do see asymmetry, the way to make the diagnosis, confirm the diagnosis, and really start to evaluate how we're going to start thinking about treatment is based on x-rays. So typically it is an x-ray kind of from up here down through the pelvis, getting a view of the entire body from the front and from the side. So typically 2 views where we can see the entire spine. And then we can evaluate that sideways curve, we can quantify it, and then we start coming up with a treatment plan with you and your child based on their age, their gender, the curve pattern, and the amount of growth, most importantly, as well as the size of the curve, the magnitude of the curve. Because those are the things that really are prognostic or are most predictive of whether or not these curves will change and get worse.
And it's important, I think, too, to add in that we really like to get standing x-rays or sitting x-rays against gravity, rather than getting them laying down, because that's the way that the body is going through space, is being upright against gravity. And every one of these curves will be lower magnitude when we're laying down. So we really want to see them when they're upright. Absolutely. So the other thing is, when you mentioned, the upright and the curve, is that the way we measure scoliosis is a Cobb technique. So we're looking for 2 vertebrae which are the most angled relative to each other. So as the curve's going up, if you have 2 vertebrae that are most angled, we're measuring against those vertebrae. That's kind of our language that we use when we're talking about, so that we can quantify the magnitude of the deformity. So as best we can, Brian and I can talk about apples to apples rather than apples to oranges with different measurements. So that's our language with scoliosis, is in degrees. And obviously 0 degrees means that everything is stacked up straight and there's no curve. But as they start to curve and angle, that's the language that we use. And we have to have at least 10 degrees of that measure to call it scoliosis, because anything less than that is falling within the normal range of the population. So getting more than that is what we call scoliosis. And minor degrees of scoliosis are very, very common in our population. It starts to get, as the number gets higher, there's fewer and fewer people involved, and fewer people actually need something like a surgery. But there's a lot of people running around who have a very mild degree of scoliosis, who are doing very well as adolescents and as adults. So Brian, one question I think we get commonly asked is, I'm going to just give a little scenario. So my child's got scoliosis. Let's say they've got 15, 18 degrees, which is mild to Brian and I, but it is scoliosis. And what activities are appropriate, are safe? And another correlator that was, any of them make my child's scoliosis worse?
So I think when I pull up X-rays in a room with a family and we have a 15 or 18 degree curve, it can look very dramatic. Seeing that X-ray of your child and seeing that curvature, it is visible. It is still relatively mild though, if you're talking about a 15 or 18 degree curve. Now, as best we know, based on the research we have on scoliosis, there's not any activity that a child is going to do that's going to make things better or worse. That what drives the progression of the scoliosis is growth, not wearing a heavy backpack on one shoulder or tumbling and doing backflips. And when I see patients with a 15 degree curve, I want them not to think of their back as abnormal. I want them to think of they have a back that has a little bit of a wiggle in it. It is still strong, it's stable, it moves normally, and there are no activity restrictions, as far as I'm concerned, for almost all children with scoliosis.
So you think gymnastics is okay, and tumbling, and swimming, and contact collision sports, if they want to do that?
Well, we could have a whole nother discussion about risky sports. But as far as the back is concerned, there's no reason not to play. There's no sports that I would restrict kids from.
Okay. So as we look at these kids, and you mentioned we quantify their scoliosis, and we start talking about treatment, if it needs treatment. Observation is one thing we do quite a bit of, where we just wait and watch. And that is something when somewhere in the neighborhood of under 20 degrees is certainly, in my book, I just watch that. I think 20 to 25 degrees of the scoliosis, it gets a little bit in the gray zone depending upon what families want to do, how interventional they are. And I think that's a time point that I open it up to families to say, are you more on the I want to do something side, or are you more on the I'm going to wait and watch? And I think you can go both ways with that kind of a magnitude of a scoliosis, because we don't know what's going to happen with that 20 to 25 degree curve all the time. As you mentioned, there's lots of things that contribute to that, such as the age and especially too where the curve is located. So when we get to those curves which are in that neighborhood, there is something new that's popped up the last, 5-10 years. We talk about exercises, whether it's scoliosis specific or the name a lot of you have heard about is Schroth. Can you tell me a little bit about, your perspective about what it is, what demands it is of the family to do those kind of ACT programs? And, because there's a few of them around here in St. Louis, and there's many around the country. Can you just tell us a little bit about your thoughts about those activities?
Sure. Obviously, exercises for scoliosis seems would be an ideal treatment. That it seems low risk. The burden is less than wearing a brace. I think unfortunately the evidence we have on exercises alone for scoliosis, particularly those curves that we are worried about progressing, is there's some evidence that there may be some benefit for doing these exercises. And these are scoliosis specific exercises, not just regular physical therapy. They are much more intensive, time intensive and labor intensive, and can often be a bit more of an out-of-pocket cost for families as well. So I do have a Schroth provider that I'm in regular contact with. I think she has a very similar approach, that Schroth or other scoliosis specific exercises in my mind, are for, it's done in addition to a brace, never instead of a brace. And with the understanding that this may have a benefit with the brace, but you may not be really getting so much out of it other than keeping the back and core strong, which I think has a role as well, regardless of whether or not it actually helps change what this curve is going to do over time.
Right.
Do you have many patients who are doing Schroth, or you send many patients to?
I don't. What I found is that, as you mentioned, it's very time intensive. It's very difficult for people to have access to someone that is skilled in the area. It takes a lot of commitment to doing it. And I think, like a lot of things, there are individuals that start off on it and then they fatigue. It's hard to keep being diligent about doing the exercises. And I think that it causes a little bit of potential financial fatigue too, for parents. And it takes a lot of time and effort. We only have 24 hours in a day, and I think it's hard for people to do that. I agree with you, everything you said. And another thing I encourage people to do is, engage in a very aerobic activity. I think that's a wonderful thing for adolescents. I think in general, what we see is a declining number of our adolescents as they get to high school because of varsity sports, other activities start selecting things out and they become deconditioned and less active. So I think a lot of times doing in a sport that's aerobic is probably as helpful as a lot of, not necessarily, I'm not arguing about the Schroth and Scoliosis specific stuff, but just about therapy and those kind of things. I think it's really helpful to have those kids engaging in health overall and their wellness, and improves their attitude and self-worth immensely participating in those kind of activities. So I think that's really an important aspect for these kids to be doing also, especially if they're wearing a brace, because they get deconditioned. And you take it off, as you do the same thing, correct me if I'm wrong, but you take the brace off, go play your sports, go swimming, go do all that stuff, because you're still normal. You just got a little curve in your back, but you need to be healthy still. And Brian, I'm going to ask you, there's a couple of people posed a couple of questions.
Yeah, just saw those.
We should answer them. And one question that I'll ask you, and I'll answer the second one. What about a trampoline with respect to restrictions? It's a great question. You can answer it two ways. You can answer it with a spine question and about everything in general too.
So asking a pediatric orthopedic surgeon about trampolines is a dangerous thing. So as far as scoliosis is concerned, I do not think you should be restricted from jumping on a trampoline. There is no reason you can't be on a trampoline because of your back. However, trampolines are inherently dangerous. And if we are going to be on a trampoline, it should be one person at a time. We're not doing backflips. We make sure that the trampoline is in good repair. So basically like the least fun trampoline jumping ever, straight up and down. Yeah.
Yeah, and the walls, sometimes even they have padding. Right. Even with, as I agree with you, that I had my 20 plus years of doing this, I've seen major injuries from trampoline that were not related to the spine. In fact, very few were ever related to the spine.
I've never seen a spine injury from a trampoline.
I've seen neck injuries, but pretty rare with everything else.
Yeah.
Thank you. The next question, which I'll go ahead and take that one. Are there any sports activities that could be helpful in improving scoliosis? I've heard swimming. Again, there's no particular exercise activities that will improve scoliosis. Now, scoliosis can be stagnant for a while, and it's related to how fast the individual is growing. Because so kids grow in what's called a saltatory fashion, which means like walking uneven stairs. They may not grow for a week or a month or grow really quickly in that same time period. So what's important is that they're staying active. Swimming is a wonderful aerobic activity. It works great on your core and your back. And I think that's a wonderful kind of a low impact activity that is a great lifelong activity that they participate in. And so I think that's a wonderful, but will it improve scoliosis? I don't think it's going to improve scoliosis per se, but it's a great activity with a very low risk of injury as opposed to Brian's trampoline therapy that he's advocating. No, I'm just kidding. Not trampoline therapy at all. So those are those two questions. Any other questions, please? Just, we've got about 5 minutes left, so anybody has any questions, please feel free.
There's another question about bracing, which I think is probably the next thing that we should probably go into. When do we start thinking about other types of treatment like bracing, and what's the role of that? What's the purpose?
So when we look at bracing, I mentioned briefly that about 20 to 25 is a gray zone on the Cobb measure. As we get more than 25 degrees, probably up to somewhere 45, 50 at max, that bracing can probably have a positive impact. Now we're talking adolescents. I'm staying out of the younger ages because that's a little different problem. But we're looking at adolescents. So anywhere from like 20 to 25 up to 45 or 50 is where we can brace. Now, the purpose of a brace is to try to prevent scoliosis from getting worse from where we start. So if you look at all the big brace studies, they pretty much say that success is defined as not more than 6 degrees of progression for some, other ones going to surgery. But certainly what they've seen, and they follow these kids, is that when it doesn't change, that's success. So if you start at 25, 35 degrees, that when you complete bracing, some people will call that success for it not to get worse. And that's really the aim for our scoliosis. It's pretty rare that any of our kids that are wearing a brace actually get straighter or get cured in it. They look better in the brace than out of the brace, but they still have the curve at the end. Bracing is something that we do quite a bit of. As soon as the kids get into that area, we start looking at bracing as an option, and it takes a lot of discussion with family, because giving them a brace doesn't somehow magically work if it's sitting in the closet in the bedroom and they're not wearing it. And they have to wear it. They've got to put it on. They've got to have it snugly fitted. It's got to be appropriately sized by a certified orthotist to make sure it's doing what it's supposed to do. And it takes regular follow-up with us to be able to see if it's working at all. And let's see here. Right, let's go to another question.
A couple of specific questions.
Yeah, okay. My daughter has a 29-degree upper curve and 39-degree lower curvature. The orthopedic surgeon said we've been to said to treat, should she be in a brace at least? She is 15, but I think you just answered it. But not exactly answered it, right? Because one thing that's really important to know is this young person still growing? Because bracing is really something to be used only when we are growing, because we're trying to prevent it from getting worse. Well, I don't usually brace people when they're done growing, and that's important to make that assessment. Brian, how do you tell people, how would you answer this with someone and their age, only knowing their age?
So typically, girls are going to get through a majority of their vertical growth by around age 14 or so. You know, the way I think about bracing is we're trying to direct growth. So once growth stops, there's really no point to a brace. It just pushes on you and tortures you. You take it off, spine settles back to the position it was formerly in. That when you are growing really fast and you can get the spine to grow more this way, rather than trying to go all sorts of different directions, that's when it can be useful. So typically a 15-year-old, regardless of the size of the curve, is not gonna, in most cases, have much benefit from bracing. But 15 is, everybody matures at a different rate, speed, time. So can't just from the age know exactly how much growth is left. But in general, most girls are gonna be through a majority of their growth at that point. And then I think the other question was for a 12-year-old with a 50-degree curve.
That's a little different problem. So if we're to say that this 12-year-old is an average 12-year-old that we would see in our office with a 50-degree curve, I think we say, well, they're over 25, they deserve something active to do. When we get to 50, it gets a little bit into a gray zone, and we don't have time to get into all of that. I think for myself, if we're going to stick to does a bracing benefit, I don't think bracing benefits when you get more than 50 degrees, because this person's in the surgical range to me. So whether, and surgery is a whole different half-hour discussion here on Facebook to discuss surgery options, except for the major ones. But I don't think that I would brace, in general, a 50-degree curve in a 12-year-old, because this person's going to be going on to surgery of some type. And so I'd rather not torture the individual and then do surgery for that. So we're kind of at 5 o'clock. Any last comments, Brian, before we wrap this up?
I think there's one last question.
Okay.
I was told that idiopathic scoliosis should cause no pain, but my daughter has presented with pain in her right shoulder blade. Is that normal? So back pain in general in children and adolescents, just like in adults, is something that I think is fairly, I don't want to say it's routine, but very, very common. So scoliosis in and of itself isn't necessarily painful, but having back pain, muscular back pain, pain around the shoulders or lower back, in addition to scoliosis, is extraordinarily common and isn't necessarily indicative of something more sinister going on. And in fact, oftentimes that back pain, while maybe not directly caused by the scoliosis, might lead to an evaluation by the pediatrician where the back is examined a little bit more closely and scoliosis is found. So would I say that that's normal? I would say that a lot of my patients who come in with scoliosis do have some sort of back pain.
Yeah, I would agree. It's very common. And the pain that's episodic, that is activity related, is probably all muscular back pain. There's a lot of variety of what back pain could be, but things around the shoulder blades, very common that's musculoskeletal pain related to scoliosis, and therapy or exercises can be very helpful to that also. So I want to say that I want to thank everyone for watching this half-hour session on Facebook Live with Brian and myself. Washington University Orthopedics and Pediatrics, we see patients at Progress West. We see at the center, especially care center out of Mason and Forty here in St. Louis, and at St. Louis Children's Hospital, and we're also at Shriners Hospital. And Brian, any last comments before we wrap this up?
Thank you all for watching. If this brought up questions, I encourage you to reach out to your pediatrician. And of course, we are always available as a resource to talk to you or evaluate your children if there are concerns.
I totally agree. Well, thank you very much, Brian, for having this discussion with me and having this talk here live. And thank everyone for watching, and be on the lookout for other Facebook Live broadcasts from Washington University Orthopedics. I want everyone to be safe and healthy. Wear your masks, all right? And take care, everybody.